But thank you so much for listening to me. This is a topic I'm really, really passionate about. I was trying to work out what I'm a specialist in. I am actually a specialist in owner communication. I'm a specialist in seeing how we can advance how we manage osteoarthritis in first opinion practice. So having this opportunity to come and talk to you is massive, so thank you. What I'm hoping to do today is talk about, go forward, is acute on chronic pain management and whether we actually identify and best manage it in first opinion practice. And following on from Helen, can I collaborate with you? Brilliant. Because I don't think we do. And I think there's something that we could actually start doing tomorrow to really change the way that we manage OA in our first opinion cases. So what we're going to do is have a quick look on this concept of acute on chronic pain. What I hope to do is inspire you that human translation is possible immediately, tomorrow, in fact, for the benefit of the animals in our care under this concept of one medicine. Now, this is how we would look at OA progression. We would see it progressing over time, slowly increasing in overriding pain, populated by these acute flares, so these acute exacerbations in pain state. And over time, these acute flares will increase in intensity, duration, and frequency. Now, that's not how I learned OA. 22 years ago at university, I kind of learnt it a bit like this. That was my understanding of OA, the disease in the canine and feline. So as you can imagine, as a first opinion practitioner, what do? They arrive, first line medication. They come back a few weeks, a few months later, add something. Come back a few months, a few weeks later, add something. And again. And suddenly, we have a situation where we have stockpiled all of these approaches, but if we take away my understanding of what the disease was and actually look at human translation, you'll realise that potentially you could argue, have I over-medicated? Because I've been following the course of the disease that I imagine, but not actually from what we know from human literature. And that creates a little bit of a problem. Because, yes, admittedly, being able to distinguish flare from the worsening of symptoms is very difficult, and this is from a human journal. But what we do have to say is there a potential that the way we're currently managing OA is potentially jumping into polypharmacy too quickly? And with that, do we have complications that we're creating with managing these adverse events in our pets? Are we making it more complicated? Are they necessarily doing well? And let's throw gabapentin in here. How often does that get very, very quickly prescribed? And suddenly we have a lethargic dog. He's ataxic. He's not doing so well. I think he's deteriorating, which obviously creates stress for the owner. What's going on? I don't understand. I thought you were supposed to be helping me make this case better. And then that adds to more complexity with where do I go next? What do I do? How do I fund this? And then for me, the first opinion practitioner, what the heck is going on? I've got disease, and I've also got my treatment. What's going on? There's a bit of a cauldron situation here. Now, don't get me wrong. It's complex, you know. Canine OA specifically, feline OA, we are very late to diagnose the condition. You know, following on from Richard, we are pretty slow to the party. We're waiting for the owner to observe a deterioration in their animal's behaviour that could suggest that there's a problem. And we know that that tends to be identified quite late. We have a real difficulty in actually qualifying pain in animals. Helen mentioned about the fact that we have these pain scales that we can refer to. Are they very useful in first opinion practice? I'm going to say something really politically incorrect and say no, I find them very difficult to integrate into clinical practice. 15 minutes? Not on your chance, you know. Do they look at it like homework? Yes, they do. Does suddenly the whole clinical situation change? Yes. So we have a lot of problems there, but we have great difficulties quantifying pain. You know, there's a very amazing vet called Dr. Chris Sink, and she says you won't see pain in a dog until it's 7 out of 10 bad. That's pretty bad, isn't it? But we also have problems with how do we engage our clients to take the advice that we give them. And multimodal management of chronic pain is complex. what I'm completely obsessed about. But how do we get them on board, and how do they come on that journey with us, and how do they engage with it and implement it on a daily basis? How do we actually get them to adhere to the advice that we give? Or listen to Mabel by the poo bin, who says, no, you need to use orange peel in the left ear when the moon is at the point. You know, it's very difficult for them to take the information that we're providing and engage with it on a long-term basis. And I'm definitely very passionate about this topic, lifestyle modification. And Helen, you'll probably find this funny because I'm now labelled Mrs. Rug, because I believe more rugs, less drugs. Because we don't actually engage with lifestyle modification. People don't see it as being very important. People come to the vet because they want a pill, a potion, a lotion, an injection. So when I say, actually, do you want to look at your flooring? They think I'm on a different planet. So that content of the multimodal management plan is highly neglected. But we're going to have to start taking it seriously because we've got a big problem, a big, big problem that we've known about for a while, but we've now got it in the literature. We've always said osteoarthritis is an older dog disease, but we've always said the major cause is developmental joint disease. There's a big anomaly there, isn't there? Developmental joint disease, old dog disease. What happened in the middle section? Well, we know that OA is actually a young dog disease, and this is work that's just come out from NC State. And the figures are actually terrifying. So they took 123 dogs, mixed breed, staff dogs, and they were between 8 months and 4 years old, and they radiographically assessed all peripheral joints and clinically examined them. And they found that 24% of that 123 actually had mild pain associated with radiographic changes in one or more joints. Just think of the age, 8 months to 4 years. This is a big problem. And 16% had moderate pain associated with a radiographically afflicted joint. So I think we need another plan, because if we're going to be treating these younger animals, we certainly can't start stockpiling. We can't start adding. What, 8 months old? You can start adding. So we need to think differently about this, because I know that, say, Generation Z, with their young dogs, are not going to be wanting to live in this situation for the next 10 to 12 years, their beloved pet. Now, so where do we go to look for this information? Where do we find how to progress from here? There's nothing. There's nothing in the literature. So we're going to have to jump over and do some translation, because this still remains a welfare concern. Osteoarthritis, alongside dental disease and obesity, was qualified in 2018 as a welfare concern by the lovely Vet Compass. So we've got to do something about it. Now, what we can do is we can look at human literature, and we can start learning from what you guys already know. Hate to break it to you, though. There's not much out there about acute flares in humans either. Is that right, Helen, or am I stabbing in the dark here? Thanks, good. I was a bit worried about this section. So in the human literature, there is a bit more than we've got, though, and it's worth considering. A problem that the human literature has is that they still haven't come up with a definition of what really classifies an acute flare. We know they exist. We see them in practice. They have case reports. We even create acute flares so that we can do drug trials, etc. But what is an acute flare, and how do we actually qualify it? We know it's an increase in pain over the usual or baseline pain, but how are we going to really define what is a flare so that we can study them? Is it to do with the physical presentation? Is it to do with the psychological aspects? Is it something that we can measure? How are we going to move forward? That I'm going to leave for Helen to continue with that challenge. But what we can do is start looking at their data. Something that I found really fascinating is actually, why do they exist in the first place? And this was a really, really interesting editorial. Looking at this acute flare being a homeostatic trigger. It's bringing things back to baseline. And potentially early in osteoarthritis, when we've got what's called an organ reserve, could these acute flares be almost like an inflammatory flush? You know, do they actually serve purpose? But only once the disease progresses and we run out of this organ reserve do we start finding that these flares start to increase in severity, duration, and frequency, and obviously have a massive impact on suffering. So are we going to find, actually, they have a really important role to play as a homeostatic reboot? Or are they involved in disease progression? And that immediately makes you wonder, do you get in immediately and challenge that acute flare, or should you let it happen a little bit because it serves a purpose? Should we blanket treat, or should we allow a few of them to slip through? Still a lot to learn. But what we do know is that for many people, the lived experience is recurrent fluctuations. Now, I know that I didn't treat OA like that. You know, from university, once they've got pain, they've got pain. And they stay on that med. That's how long they stay on. Oh, they pretty much stay on for life. So when we listen to that, we're like, are we potentially not teaching our clients to be more observant so that they can personalise the care plan to that animal's needs? And what we need to really learn is like the unpredictable pain, these episodic flares. This is important. This is really important because this is where the suffering comes from. This is the distress. And for any vets that are in the audience, first opinion practice, this is what we're seeing. We're seeing the flares. I rarely have an owner come into me going, I think there might be a problem, but I'm not very sure. We might have really early OA here. I see them going, oh my God, he hasn't been able to walk for the last 3 days. He looks crippled. Am I going to lose him? So we know that we're seeing the acute flares. There's not many studies to refer to, but the ones that we do have are bigger than we will ever have in the vet sector. So 744 people is something that we're not going to see in our lifetime. 16 to 32 probably in a vet clinical study. But what I want you to take away from this is this concept that there is something potentially happening before the flare. There's a trigger. So when they actually looked into these 568 flares, they found that they fell into categories 8 physical related and 5 psychosocial and environmental. And I absolutely adored what Helen just said about a dog that is in pain living in an abusive household surely has to be different to a dog that's in pain living in a very comfortable space, rugs, household. Do we need to be looking at these differently? So just remember the 8 physical activity related. Now, do we know about acute flares? Are we talking about it in the vet sector? Yes, we are. We kind of call it something else. So this is from the World Small Animal Veterinary Association pain guidelines, and we refer to it as breakthrough pain. And this means to me that, yeah, you know, we've got a good bed to bring further knowledge in this area, but this is all that I could find about it. It's very, very limited data, and we do need to expand upon it. So I'm going to propose a new idea, and this is very much from human guidance. Do we need to actually be teaching veterinarians to consider OA in a different manner? Is this acute on chronic part of a framework that we need to be presenting to them? That actually that animal, that slowing down dog in front of them, actually has a combination of things going on. This isn't just chronic pain associated with just the joint that's affected. Yes, we've got our primary disease, we've got this amplified nociceptive signalling system, we've got all the consequences of having been in pain for a while. Sleep deprivation, physical changes, physiological changes, cognitive and emotional changes. But we also have a dog that is being afflicted by these acute flares, these acute exacerbations. So should we be actually framing osteoarthritis differently to our students, to our new grads, etc.? Now, something that I love from the human sector, and I really hope that we can get this across to people learning about the disease, is you could almost divide it into 2. We have the disease and we have the illness. So all of the things that come from having chronic pain, which is a myriad, emotional, cognitive effects. This is the illness, and this is what we're actually trying to manage because we're still not great at doing the disease, let's be honest about it. And our attention, and where we can make amazing inroads, is the illness. And is that how I get rugs into the conversation? Yeah? And another way that we could look at the human work and say, let's bring this over to the vet sector, start using it, is let's look at short-term strategies and long-term strategies. Let's really expand the way that we teach and understand OA. So going back to those 8 physical and 5 psychosocial triggers, this is what I'm hoping we can really use tomorrow. Like tomorrow. You can download the tool and you can use it tomorrow. We know from the human sector, when they looked into these triggers, they were divided into incidental, idiopathic, and end-of-dose failure. So what was happening prior to that person having that acute exacerbation in pain? I've circled this section here because in the vet sector, our patients are non-verbal. So when we see a deterioration, we can't say, is it your knee? They'll be like, We have to look again. We have to make sure we haven't got comorbidity. We have to make sure that something else hasn't cropped up. So we should be reassessing these acute exacerbations. Whereas in the human sector, somebody could say, I assure you, it's radiating from my knee. It's the same pain that I felt before. It's another flare. So we have these categories that we could investigate. Now, just to be, appropriate, these triggers, these categories, these triggers of the acute flare aren't standalone. You can't say it was definitely me slipping off that stage was the only thing that caused that flare. We have these influences, what are called distal causes, my overall health state, if I was carrying too much weight, etc., will also influence these triggers. But when we're looking at trying to identify these triggers so that we can help our clients with their dog so that they avoid these acute flares in the future, we can look again at human data. And this was another study, more in line with vet numbers, only 67. But what we did find is that many of these people reporting a flare had something happen within 48 hours prior to the flare, generally a physical event that exacerbated the signs. Now, that's something that we can work with immediately. Us in the vet sector, we can use this. If we can identify what these potential triggers are, we can potentially avoid these flares in a more kind of preventative manner. So from guidance from the human sector, we know that this is their approach. This is their conversation with the patient. We're going to be looking at that long-term therapy, but we're also going to be giving you the empowerment to have a flare pan. And we also want you to try and identify what those triggers were so we can avoid it. We don't want you having these flares. Can we convert this? Yes, we can, very easily. So maybe a vet version would be caregiver education, so they can understand the long-term management and the influence, but also encouraging owners to monitor and reassess and look for triggers, things that preceded that acute deterioration. Now, I'm hoping to be helpful. So I worked for an amazing guy many years ago. He's called Dr. Andrew Denning. And he said to me, Hannah, do not come to me with problems. Come to me with solutions. And it was really good because all of his staff would be like, I haven't worked out this one yet, so I won't talk to you. So it kept everybody at bay. So my solution is to start work on the education. And this is a tool that we've created in CAM that we hope will be of use to people. It's pretty extensive. This is the vet version. And it's available for free download. And it talks about all of these different approaches very comprehensively, using many, many different learning tactics. And what you'll find is also, we have brought into it, as you can see, it's quite extensive, also these integrative tools that they can use within the household. Generally, people live with other people in the house, and communication in that household can be a little bit challenging. So the dog may be having a flare, but no one else, bar the mum, knows that that's happening. So we have these tools that you can attach to the fridge, and even these wonderful fridge magnets, so the family can communicate to each other that something's going on. So we really believe in improving communication as well as education. So this is what I feel that I've learned from human translation, is reframing how we look at this disease, bringing in information from another discipline, and being able to immediately put it into practice. Now, what I want to say, because I think vets, we work blinking hard. We do have two masters. We're not only treating the patient, we're also treating the caregiver. The communication skills that we need are incredible. And I think this sums it up beautifully. So thank you so much for listening to me. If you are interested in following any of our work, you can find us at caninearthritis.co.uk. Thank you for the opportunity.